Good evening, good evening, good evening, and welcome to Couch Conversations with the Doctors. What night is it tonight? It is Monday night, and it is time for Couch Conversations with the Doctors. As always, we're going to go around our great esteemed panel, introducing everyone that is here, starting with the urologist of the stars who says that he is happily retired, but who believes that? I mean, come on. Is there a doctor in the house? It is, and it's our very own Dr. Terry Mason. Dr. Mason?
Thank you, Nikki. I'm always glad to be here with you and the congressman and to add what I can and with my other colleagues. I'm sure we'll have another spirited conversation this evening, and I look forward to it.
Outstanding. Well, to the man who has the best art that there is, and that's our very own Joseph Harrington. Joe?
Thank you, Nikki, and thank you, Congressman Davis, for providing this platform. Like Nikki said, my name is Joe Harrington. I've worked in a lot of different fields, mental health education, but mostly public health and healthcare. I retired in 2017 from the Illinois Department of Public Health, where I was a regional health officer for Cook County and an administrative law judge.
Outstanding. Want to say hey to Yolanda Williams that's here. She says good evening to everyone. Want to say hey to Keisha, Kalila, and Vernita over at DLB Printing that is watching. Want to say hey to the Core Center. They are here. They said that they are working, but they are definitely watching. Hey, Deborah Williams. I see you there. Want to say hey to Deborah Williams. Want to say hey to Dr. Erica Taylor, who is watching just as well. Hope you're having a great time where you are. All right. To the man who says I threaten him to be here every Monday night, but he is always on time. That's our very own Dr. James Miller. Dr. Miller?
Well, good evening, everybody. I want to thank Nikki and Congressman Davis for providing such a platform that we are able to come and discuss issues and possible procedures and things that we can do to help our community to grow and thrive and to be healthy. You know, there's a lot of things that we need, but none of them is as important as being healthy. Sometimes, money can't buy health. So it's important to know what you can do and to be healthy. And oftentimes, things that you can do are there for you to do, and it can avoid the use of money because if you're eating correctly, if you're exercising correctly, sleeping correctly, avoiding stress, man, that can lead to good health. So we're here to talk about those issues and hopefully answer some questions and help somebody through their troubles.
Outstanding. Outstanding. Want to say hey to President Sanders over at Malcolm X College. Thanks for joining us. Want to say hey to Dr. Roy Walker, who was here just as well, also from Malcolm X College. Want to say hey to Pat Dow. Hey, Pat. We see you there. That's Alderman Pat Dow. Want to say hi to Sean Kennedy. Sean Kennedy says good evening to everyone. D. Sharon Grant is here, and she says hello and good evening to all. Want to say hey to Jared Campbell, who is watching just as well, along Beauty at HSI is watching. Shirley Fields is here with us just as well. Hey, Shirley, how are you? Great to have you here with us. Sonia Davis Watts from Geo is here just as well, and Vicki Allen is here with us. Want to say hey to her just as well. Well, to the man who is the physician by day and the DJ by night on the ones and the twos, that's our very own Dr. Pete. Hey, Pete.
Hey, Nikki. Again, thankful for you and the congressman for creating this forum. We are looking forward to a spirited conversation. I appreciate being amongst my esteemed colleagues. Looking forward to sharing some health information that might be helpful.
Outstanding, outstanding. And to the one who makes it possible for us each and every Monday night, to the one who teaches us that true wealth is our health, that's our very own Congressman of the Illinois 7th Congressional District, Congressman Danny K. Davis. Congressman?
Well, let me just welcome all and thank you all. As a matter of fact, I was at Malcolm X on Friday, and I saw so many young people there until it was just enthralling to be in the midst of all the people that I saw at Malcolm X. The governor had an event and an activity there, and there were just people. And then I ran into one of the young staffers who's also an alpha. And we got to talking after I had completed what I was there for. And he was telling me about all of the wonderful things that were going on. And he even was going to try to get me to run by the president's office. But I could never stay anywhere that long to do what I came for. I was trying to get someplace else. So I missed President Sanders, but I did see some of the faculty. They were preparing to get ready for spring break and had some libations and different things. And it was just a great visit, even though it was not planned as such. And it was good to be, because Malcolm X is where individuals can get education and training for a profession in the health industry. And they don't have to become physicians. They don't have to be doctors. They can be nurses. They can be lab techs. They can be all kind of wonderful things. And if they get trained, they don't ever have to worry about a job, because you cannot transport the work that health professionals do to out of the country. You can't take those overseas. Those have to be done right in the hood. So I will say hello to Dr. Sanders and all of the staff at Malcolm for the wonderful job that they are doing. And let's get it on, get into some of this medicine stuff.
Outstanding. Want to say hey to Linda Johnson, who is here. She says, good evening to everyone. To Elijah Grace, that's here, our former intern. Hey, Elijah, how are you? So good to see you there. To Phyllis Murray, who is here, and Marcel Jackson, a.k.a. Action Jackson, that is. Want to say hey to Betty Johnson, who is here with us just as well. And also to Robin Stager, who is here with us also. Well, Pete, tonight, if you can lead us off, I'm going to give you the questions that we have out there. You guys had such a robust conversation prior to, and I know you all will get back to that to share with the community on actually what's going on in Congress in reference to our health care and how we need to deal with what's going on with some of the things that some of that administration is doing. But Pete, we have tons of questions about respiratory disease. Exactly what is respiratory disease? What is the difference between emphysema, COPD? Why are there so many upper respiratory infections? How are we dealing with RSV? Well, I know you guys will have a robust conversation about this upper respiratory disease, and I am concerned just as well as one who suffers from asthma. How do we keep this under control?
Yeah, Nikki, this is a very good question. So when we talk about respiratory diseases, we sort of divide it into restrictive diseases and the other category is obstructive diseases. And restrictive, we're really talking about autoimmune diseases like sarcoidosis. There are other mixed connective tissue disorders that can cause the lung to be restrictive or difficult to inhale. But for obstructive diseases, respiratory diseases, those are things like that our audience just mentioned, which is COPD, chronic obstructive, hence the name, chronic obstructive pulmonary disease, and emphysema or bronchitis. So those are all three very close cousins that present themselves much the same. So, and of course, asthma is in that. The only difference with asthma tends to happen with younger folks, and it's reversible. So, with chronic obstructive pulmonary diseases, these are people who usually have a history of smoking. And what happens with the tobacco and the smoking is it destroys the small lung units that's responsible for exchanging air, meaning exchanging oxygen for carbon dioxide. That's your primary purpose of the lungs is to get oxygen and then blow out CO2. So when you destroy your lungs by years of smoking like that, what happens is it doesn't do a great job of that exchange. It doesn't do a great job of taking in the oxygen and then blowing out the CO2. And so usually what happens is those patients require medications like albuterol and Atrovent, sometimes a steroid inhaler to assist in the or reducing the inflammation that's happened as a result of the years of smoking. And sometimes for asthmatics, it's typically like an immune response where the immune system is telling the lungs to constrict. Okay. So those patients have a predisposition for getting infections. So that's why COPD patients, asthmatics, bronchitis patients, emphysema, they're all the same disease. They're all the same disease, just close cousins. Many times, if you do a what we call a pulmonary function test, you'll find that these people have mixed disorders. Some people have chronic obstructive pulmonary disease and emphysema. Some people have emphysema and bronchitis. So, but what's true of most of them is that most of them got this disorder as a result of years of smoking. Now, there are some people who have a genetic disorder that can predispose them to COPD, but that's rare. Most people who have COPD or emphysema, they got it from years of smoking. And even asthmatics, there are some people who have asthma from a being a child or from a teenager, and then they end up smoking over the years. So those people might have a mixed disorder too. They might have COPD and asthma. The big difference between asthma and COPD is that asthma is reversible. What does that mean? That means if I give you the methacholine challenge test, which is what we give patients to a diagnosed asthma, what will happen is it will elicit for a bronchoconstriction, but then once I give you the beta 2 agonist, which is like albuterol, things like that, then that'll open up the lungs. COPD is very different. COPD, it has a poor gas exchange no matter what you give it. And then the real true treatment for COPD is really patients who become hypoxic, which means their oxygen level is very low. So over time, what happens is your lung function goes down. Even for people who never have a tobacco history, who never lived in a highly polluted area, as you get older, your lung function just goes down. But that decline is not as steep as if you were exposed to environmental pollutants or if you smoke cigarettes. If you smoke cigarettes, that decline is very steep. So all that being said, I know Dr. Miller is dying us to pitch in here, but that being said, those patients have a predisposition for developing all types of respiratory infections, not just RSV, that's a virus, but influenza, another virus, COVID. They develop a predisposition for pneumonia, bacteria. So you have to be very cautious once you develop COPD. Have to be very cautious about getting your vaccines, making sure that you're up to date with those vaccines, and making sure that you're on your appropriate inhalers. But it's important to realize those inhalers do not improve your mortality. It only improves your lifestyle, meaning they do prevent you from having to have frequent emergency room visits. They do prevent you. They do keep you living a sort of quality life, but they don't improve your mortality, meaning it does not help you to live longer. And so that's important to realize. Now, I'm saying continue taking those inhalers, but it's important to realize that they even those inhalers have their limitations. Dr. Miller, did you want to?
Yeah, I would just add to that that it's important that people who do have COPD, asthma, or emphysema, to recognize that these conditions put you at somewhat at risk, because if you do get an infection in your lung, that will make you less likely to be able to get past your asthmatic attack, or cause you to or can cause you to have an exacerbation of your asthma or your COPD. So it's important, if you do have these conditions, that you recognize, I need to make certain that I got my flu shots, that I got my that I if I do have a problem, and now suddenly I'm not only just short of breath, I'm coughing and producing sputum, that I see a doctor, that I get it evaluated earlier, because sometimes the problem happens that people just wait too late, or wait, and that means that the longer you wait, the more virulent your process is, and then that means that it's become a little bit more difficult. Now you end up having to take steroids or some other medication that maybe you would not have to take, that does have its own risk of damaging your system, or making you susceptible to other kinds of disease process. So realize that when you do have these problems, that you have some other things that you need to do as well, to try to prevent yourself from, or to get these things taken care of when you do get other secondary conditions in your lungs.
I'm sorry, go ahead, Joe.
No, you go ahead, Terry.
No, I'm just going to say that, cigarette smoking has had a long history. And we've known a long time ago that cigarette smoking is addictive. We just don't blame this all on patients, people. But these agents are known to have addictive qualities, which make it very difficult, not impossible, but very difficult for people to abstain from them. And so we always try and we demonize the victims, but we've got to understand that there's a lot of money behind. And as I go through, and I'll stop in a minute here, as I go back and look at some of the old commercials that I used to see, there were even commercials only on where physicians were used to actually help sell the cigarettes. And they had a thing about doctors smoke this. I mean, different billboards and what have you. So we want you to know that, yes, this is a bad thing. No, it's not totally all your fault, but there are places and are things that are available that both Dr. Miller and Dr. Dr. Pete, can direct you to, because it is not a hopeless situation, but it does take some work. And I'm going to stop right there to allow my other colleagues comment on just how difficult it is and how addictive cigarette smoking can be.
I got to take myself off mute.
Exactly.
Yeah, I wanted to jump in, and I'm going to piggyback on what Dr. Mason said, but I'm going to start at a different point and come back to it. One of the things I think is important for our viewers and possibly our listeners to know is that I didn't hear anybody talk about risk factors, and I didn't hear anybody talk about heredity, because we're talking about something that's more environmental in terms of what causes it to happen. I mean, you might have a predisposition, but unlike a lot of diseases where there's a direct connection in terms of family history, it's not the same for respiratory disease. And I think that's what's important for people to understand. What I wanted to say relative to what Dr. Mason said, and people probably know this, but they don't understand it, is nicotine is highly addictive. And people don't think about that. It's found in the tobacco plant. It's a stimulant, and it acts on the central nervous system. It produces a variety of effects. But the important thing is the government now regulates the amount of nicotine that you could have in a cigarette. But again, it's highly addictive. So once you get a hit, you want another hit, and then another hit, and another hit. And I've heard people say that it's more difficult to get off of cocaine than it is to get off of cigarettes because it's so easy to do, it's so available. So it's almost like this mismessage in society. It's okay to smoke and be addicted to smoking, but it's not okay to use cocaine.
Yeah.
Well, that's a big pill to swallow. Want to say hey to Miss Deborah over at Coleman's Barbecue. She says hello to everyone. Audrey J. Cox is here and she says good evening to everyone. Sandell Scott is here. And Sandell says good evening to everyone just as well. Want to say hey to Tina Hammond, who is here with us. Mimi Brayboy, who is here. Karen Scott is here with us. Our our clerk of the circuit court, Mariana Sparopoulos, has stopped by and she's here with us just as well. I want to say hey to Commissioner Donna Miller, who is here, to Arlene Spencer, who is here with us just as well. Melinda Maxwell, who is here, and Judge Marianne Jackson. I want to say hello to them. Well, Dr. Pete, the question comes up is, with all the respiratory issues that we have in our communities, why are the numbers of people with pneumonia going up? Everyone I know lately has had some form of a pneumonia. Where does it come from and how do we permit it? Is this a fallout from COVID?
Yeah, I don't know the data on this that that post COVID our systems are more susceptible to pneumonia. But if you think about what pneumonia is, um, it is inflammation of the lung units that occurs as a result of a bacterial infection, right? So if you think about pneumonia from a epidemiological perspective, Streptococcus pneumonia is a bacteria. Staph pneumonia is another bacteria. You could have a viral pneumonia. There is viruses that causes that inflammation of those lung units that fill with fluid. And again, the problem is when that inner lung unit does not becomes inflamed, it doesn't exchange oxygen very well. So, and patients typically will exhibit things like shortness of breath, fever. They get the chills. One of the things that we were taught in med school is that with people with streptococcus pneumonia, they can, for the most part, be completely normal one day, and then people with strep pneumonia can almost tell you the minute they got infected. They can tell you, I was walking on this third step of my house and I came down with shaking, chills, fever, I got hot. Like that's the classic sort of presentation of someone with strep pneumonia. But the key is for those patients is getting them to care right away. A chest x-ray to make sure you're not dealing with a double pneumonia. Make sure you're not dealing with a fluid accumulation along the lungs, like a pleural effusion, and to start antibiotics right away. So the problem is a lot of people, they will ignore the symptoms or they don't feel quite so bad. Now, strep pneumonia makes you feel pretty bad pretty quickly. Like a viral pneumonia, not so much. They sort of, it's more of an insidious kind of presentation. They don't feel quite as sick. Fever's not as high, right? So strep pneumonia is going to cause a fever of 103 in an adult, so which is very rare. But like a viral pneumonia, you might have a fever of 100.1. So those patients aren't as sick and they don't present quite so aggressively. But either way, if you have an underlying pulmonary or respiratory condition, it just sort of quadruples the risk, right? Because you can go into respiratory failure really quickly because you already got a diseased lung or a lung that's not functioning at its normal capacity as a result of the things we talked about already: COPD, chronic bronchitis, emphysema, asthma. So now if you add that to an active infection like a pneumonia or influenza infection, then that person has a high risk for going into respiratory failure. So you want to get them to the ER really quickly so we can get one is intervention started. So we like to get at the antibiotic started, IV. I tell some of my patients who come to see me in the hospital and they've had these fevers of 103, and I'm like, you come see me in my office like that, trying to avoid the hospital. Guess where I'm gonna send you? Straight to the hospital, okay? Because the oral and the antibiotics that you're taking by mouth takes time to get digested, and that might be time that we don't have. So if you're spiking fevers, you are severely hypoxic, your oxygen count is less than 92%, then we're sending you straight to the ER. Why? Because I know I can get IV antibiotics in you. I can get a chest X-ray, CAT scan if I need to, and most importantly, give you oxygen until your body's able to get over this infection, which may take a couple of days. But that's my answer to that. I don't know. Did I hit
Yeah,
everything?
let me just add
Yeah.
a couple of things. Is that the lungs are so important. Without them, that means that you can't exchange oxygen and carbon dioxide, which are essential that you do in order to have life. You got to be able to take in oxygen and maintain a certain level of oxygen in your blood, and you have to be able to eliminate the carbon dioxide. Now, uh, it is important because once your lungs start failing, then you have a medical emergency. And I think one of the things that Dr. Pete says, he wants you to get to a place where medical emergencies can be handled, which is not in his office, but because you may need to be intubated, you may need oxygen, you may need things that is not readily available in the office. So you have to look at these things and take them very serious. And oftentimes we understand people, they have these conditions. They may be coughing, they may be having a fever, and they feel that it's going to go away. I just got a cold; it's going to go away in a few days. But you have to, when you're dealing with certain organ system, your lungs, your heart, your brains, and when they begin to manifest abnormality, you need to take those symptoms very serious, because oftentimes you don't have a long time to get it corrected. So you need to get what can be corrected as soon as and quickly as possible.
So, which ones of these are infectious? I got on the airplane this morning. The gentleman who was sitting next to me had on a mask, and he said to me, uh, "You might want to get a mask. I've got a cold, and we don't want you to get sick." And so I took his advice and called the attendant and got myself a mask. So, and I thanked him for looking out for me, although I wasn't sure exactly what he was looking out for. So,
Yeah.
so
So yes. So the problem is obviously most of the time he or other individuals may have what they call a cold, which is sort of a term for a conglomerate of symptoms like coughing, feeling tired, or lack of energy, just not feeling up to what they normally feel up to, as having a cold. But a cold can be, but what some people are calling a cold may be an early stage of pneumonia. It could be an early stage of COPD exacerbation or bronchitis. And if the exacerbation is caused by a virus or caused by a bacteria, those it's infectious. And if they're coughing, then that puts you at risk if you're breathing in the air from the air that they expel into the atmosphere. Then you can catch the infection. That was one of the, if you remember that during the COVID time, that was the big thing, is people getting pneumonia and decompensating and really ending up in emergency situations, and situations of life-threatening situations, and even death from the very effect of COVID. So these problems are very, very serious, and you you have to address them early, because again, if the lung can't function enough, then you have to have the other things done to help you be able to receive and to exchange oxygen. And if your lung can't do it, so you can't just wait. You have to go and have some intervention.
Yeah, I want to jump in and provide some context and perspective from a public health standpoint. Um, One of the things, and Pete sort of alluded to this, that flu season really starts in the fall and goes through the winter, but the flu and pneumonia peak around December. It's cold. It's a cold weather kind of thing. As the weather starts to get colder, you see people getting more colds, and the cold can lead to pneumonia. Uh, COVID is an airborne disease, and people are getting colds and other things. Um, I actually had COVID in September of this year, and it was the first time, and I hope it's the last time in my life I had COVID. I didn't have any real problems. I was never in severe pain. I was in the hospital for 5 days. It wasn't the COVID. The COVID caused pneumonia. And so I had to be in the hospital for 5 days because of pneumonia and other problems. It had nothing to do with COVID. And so when you wear a mask, you lessen the likelihood, because it's airborne, that you will get the disease. And if you're on an airplane, even if you don't have COVID, you may want to wear a mask no matter what, because you're in a closed environment and you don't know what anybody else on that plane has. They may have a cold, so you might get a cold. They may have the flu, so you might get the flu. They could have COVID, so you might get COVID, because they're all airborne. So that's what the masking does. It reduces the likelihood that that will happen. But again, I think it's important to keep in context that these are airborne diseases to some degree. And one of the things that I know personally has happened because of COVID, one of the things that I didn't used to do is I didn't wash my hands regularly. And during COVID, whenever I went out and I came back in, regardless of where I was, even if I went out to do some work in the yard, I came back and I developed new. I always wash my hands. When I was someplace different, I always came back, and the first thing I did was wash my hands, because a lot of this is transmitted and it's very simple. Somebody coughs, and you can get some of that on your hand. You put your hand up towards your face. You rub your face, you rub your nose somewhere around, and the next thing you know, the next day you wake up and you say, "I don't feel good," and that's how the disease attacks the body.
You can rub your eyes as well, and rubbing your eye, you can actually transfer that as well. So when you're in those grocery stores or holding on to banisters, we need to make sure we wash those hands. Dorothy Murphy is here with us, and she says good evening to everyone. Sister Bonnie is here. That's Bonnie Schmetley, and she says good evening to everyone just as well. Yolanda Williams says, we appreciate you all. You didn't stop when the COVID crisis was over. We commend you for your dedication to community health. Well, Valdemir Talley, that's Chief Talley, he asked the question, good evening to all. Are we afraid of antibiotic resistance? And of course, Dr. Pete was right on the call to answer that question. He put it in writing to make sure that everyone understood that, yes, this is why we try not to give antibiotics patients with viral infections. Antibiotics only treats bacteria. So for those of you who passing around your antibiotics to your friends thinking that they got the same cold that you got, yeah, don't do that. That's not a good thing to do. Do not do that. Stop calling people, asking them if they got any amoxicillin. Cut that out.
Or some of my patients say, I just want something to put on my shelf. They just want some antibiotics to put it on the shelf. I said, you don't want that. Eventually, we're gonna run out of these antibiotics, and we ain't gonna have enough to treat real infections. So we just try to, we try to be judicious about the use of these antibiotics. We know that resistant infections are real, and it's so real to the point where this is why I also explain to patients when when they say, well, they were rushing me out of the hospital. Well, the reason why they're rushing out of the hospital is that there are resistant bacteria that's in that hospital that you do not want. You are safer in your own home with regular run-of-the-mill infections, as opposed to some of the ones that's running around that hospital. You do not want it. So we make sure you're stable, and once you're stable, we get you home where it is safe, and then you are away from all of those resistant bacteria.
One of the good things about
if you cough or sneeze around me too long, I'm gonna put a mask on anyway. I keep a whole pocket full of. Joe, go ahead. Then we got a quick question from Calvin.
Okay, this is real quick. One of the good things about big pharma is they will see an opportunity to create something that we'll be able to take and they can get paid for. So we might be worried, but I guarantee you that somebody right now is trying to figure out how to be the first to produce something that they can put on the market, and it'll be very expensive initially, but the cost will go down. That's how they make their money.
The Congressman and I both are waiting on a prescription that we have to go down so we can actually go and get it, because it's ridiculous when you go to the pharmacy and the man told me it was $580 for a prescription that I've been paying $24 for all last year. But this year they want over $500 for it. So my stomach is upset over this. Well, Calvin says, 06, got a question. I was in the hospital and they stated that I had an infiltration in my lung. They pumped me with antibiotics. I was there for 4 days, and then they sent me home and told me I had pneumonia. Was that infiltration the pneumonia?
Yes. So when they said you have an infiltrate, that means that they've taken an X-ray of your chest, and that shows an area where there's opacification, and that's what we call an infiltrate. But yeah, that is pneumonia when you have an infiltrate on your chest X-ray.
There's one other thing I do wanted to sort of put out, and this is notion about the cold.
Mm-hmm.
People don't get sick because it's cold outside, and there are some things that cold weather, cold temperatures, breathing them do. But at the end of the day, and I'll defer to my internal medicine colleagues, but there are some things that cold air does do. But the cold air in and of itself is not the cause of your sickness. You have come into contact with someone who has viruses that cause these different types of sicknesses, and that's where it's coming from. Now, the cold weather does make sometimes cells a little different and a little easier, and I'll defer that to my internal medicine colleagues. But just because it's cold outside, just because you might get cold, doesn't mean you're going to have a cold. And I hear that a lot, so I'm going to defer now. Maybe Pete, if you take that.
Well, yeah, I agree with you, Dr. Mason. I think people lean a lot on the old folklores, but it scientifically does not hold up. That being cold, increases your risk for catching an infection. But what does is, lack of sleep. If you're not anything that weakens your immune system, right? So if you're if you're deficient in certain nutrients, you're not consuming a balanced diet, all those things, a lot of stress, because stress causes stress hormones to go up, which then inhibits the immune system. Some of those stress hormones are responsible for that. So those are the things, dehydration, those are the things that can increase your risk for an infection. And then a combination of those things, right? So if you're not sleeping, you're stressed, and you're dehydrated, which most people are, especially in these neck of the woods where we're indoors a lot during the winter. We're have all this exposure to this condensed heat from the heaters that are warming our buildings. A lot of people aren't consuming the water that we need for our bodies to function and our immune system to stay strong.
Well, just to add one little thing to it, I mean, one of the things that does happen is that certain viruses like influenza tend to occur as the weather turned cool in the fall and during the winter month. So a lot of people kind of associate the cold weather with these viruses, and so they then think also that, well, I'm more likely to catch this, and they are likely to catch the influenza during the influenza season. But it's not really it's not because it's cold. It's because the virus is at an increased rate in our community, and we're spreading it from one person to the other. If we weren't spreading it, it wouldn't make any difference about what the temperature is.
Outstanding. Well, Carmen says, do we need air purifiers in our homes?
I don't know about air purifiers, but one of the things that we do need to think about is humidification. And that is having some form of humidification. In other words, moisture being put into your air into the air in your house, because if it's too dry, those delicate mucous membranes even get more likely to have a problem and make it easy for a virus to enter, whether it's through our nose, whether it's through us inhaling through our mouths, or things of that nature. And again, I think these are great questions that we need to make sure people understand what they can and cannot do to help themselves. So I'll defer to other colleagues on it, because it's really an important question that people need to understand.
Yeah, two things that and I'm just going to piggyback on that, Terry. One is cold weather weakens the immune system. So just because it's cold, your immune system is not as strong as it typically is. And one of the things that happens during the cold weather, particularly in cities like Chicago, we spend more time indoors with people. And so now you're around more people more often, so you're more likely to get sick. Most of us, particularly again in Chicago, spring, summer, and early fall, spend as much time outside as possible because we know what's coming. But when it gets cold, people are unlikely to go out, and when they go out, they're typically going someplace where they're going to be with a lot of other people.
Well, Deborah asked the question, when I was younger, I could be in the cold, shovel snow, probably didn't even feel the elements outside, even with the coat on. Now, when it is cold out, I can put a coat on and I'm shivering still when I go outside. Is this due to age, or has the weather changed?
I think
don't you all attack that at the same time?
I think it's a combination of a few things.
Probably both.
It's not one or the other. I said it's a combination. And what we need to do is look at to the things that Dr. P talked about and Dr. Miller talked about. What are we doing ourselves to safeguard ourselves from being easy targets for these viruses? And not to say that you could totally eradicate that possibility, but there are some things that we started out with the congressman when he was talking about what he did, and those are good things, practices to take to make sure that you do. The other thing I'd like to also bring out here, so that we could talk about, is asthma, and those who suffer from asthma. And I'll defer to my maybe Pete or one of the other, or the gentleman, Dr. Miller, about just what this is and how can we help ourselves protect ourselves from these things.
So asthma is a condition that involves your respiratory system, that causes bronchospasm. And bronchospasm means that your airway is narrow. And obviously, it's important that the airway be open in order for you to take in air, which it contains the oxygen, and to blow out air, which is high in carbon dioxide. So, if you're having bronchospasm, that means you're having less functional capacity within your lung tissue, and there are a number of causes for asthma. With some people, it's an immune disorder that is related to allergies, sometime, and other kinds of things that cause that affects your lung tissue and make it not as functional as it would be. And so asthma, usually we see asthma a lot in children, and that's a group of people that get asthma when they're early age, and it tend to some kids will grow out of it, but some will have it for the remainder of their lives. Um, and there's thought to be sometime that this may be there may be an immunologic, a genetic component to it, as to why certain children will have it versus other people. But the big symptoms of asthma is that you have difficulty breathing. And if one ever experienced having being unable to breathe, that is one of the worst symptoms that you want to deal with. It's worse than pain. It's you feel that you're going to feel an impending doom, like that you're going to leave here when you can't bring in air and get out air. So it's and that itself is frightening, and it creates a response to your epinephrine, and so your heart starts beating fast, and a whole bunch of other things begin to happen. And so you're frightening, and you're not just frightened, but you're frightened because of what it is that you're experiencing. So asthma is it's a real problem. It's a condition that we see it a lot in Black communities, and oftentimes environmental things that are going on, or whether there's insects and things like that in people's living units that can also exacerbate asthma, or whether people are being exposed to cigarette smoke, or just the fumes from the surrounding environment. All these things are things that will exacerbate and make you have bronchospasm, and therefore experience the bad symptom of asthma.
That is so true. I mean, the easiest way that I explain it when you're having an asthma attack is I literally feel like an elephant is sitting on my chest and I cannot move him. There is a huge weight and I can't breathe in or breathe out. You can't push anything. But I remember one particular doctor who should stay nameless, named James Miller, told me, he's like, don't wear cologne, don't wear perfume, keep that away from you. And anybody else who's wearing it, keep them away. That'll help keep down your asthma attacks. And it helped. It really, really did. It didn't stop them because there were some foods that would trigger, it. But and then certain times of the year, allergy season sometimes triggers it too. But when I stopped wearing perfume and staying away from it, it really did. So Catherine Jones says, great conversation tonight. She also says, eating healthy and drinking our healthy juices and fruits and vegetables. And then she says, we need to grow our own food from God's earth. You are absolutely right, Catherine. You're correct. Well, our next question is from Fatima. And Fatima asked the question, Fatima, hope I'm pronouncing it right. She says, I have a family member who has lung cancer who has never smoked. How does a person who has never had lung cancer, who has never smoked, get lung cancer?
Yep. There are certain lung cancers that are not associated with tobacco, and I believe there's a large cell cancer that is not associated with. It's a non small cell lung cancer that's not associated with tobacco use. usually that's a genetic predisposition. So yeah, and it's unfortunate. I think what's the Superman character? He had that also.
Kryptonite.
Keanu Reeves. Christopher Reeves.
Christopher Reeves, because he did not smoke also, but he had a non-small cell cancer that was not caused by tobacco.
Yeah, but one of the things, and we've talked about this before, but it helps to make the point. Cancer is an uncontrolled growth of cells, and so it's where it occurs that it gets the name. So it's still an uncontrolled growth of cells, and there's still a lot of things we're learning. So if it happens in the lungs, it's lung cancer. If it happens in the breast, it's breast cancer. If it happens in the prostate, it's prostate cancer. But cancer ultimately is cancer. It just occurs in different places in the body, and typically they say, well, you have cancer of the breast, you have cancer of the prostate. So it's not a unique. It may be somewhat unique, but it usually takes its name from where it occurs.
So our last question of the evening, because I know you guys hate when I say that, but the question says, how often should we get a chest X-ray? All right.
Yeah, well, chest X-rays are things that are indicated based on findings and conditions that you are displaying. If you're having, if you have no symptoms, you have no risk of, if a person has for instance, a person has been exposed to someone with TB, and they have a positive TB test. They need a chest X-ray to find out whether or not they have active disease. So that's a condition that is going on. So that will require you to have it. But if you're not having any symptom, no exposure, there's no particular time in terms of when you should have a chest X-ray. It is based on what's wrong with you, or if you have anything wrong with you, and what you've been known to be exposed to. So if you know that you've been around somebody with certain conditions, a chest X-ray may be indicated if it's an infectious problem that may occur in your lungs.
I agree with my colleague, and I'll say this: one of the things that one of my professors used to always tell us is that you never order a test if it's not going to answer a question for you. So I don't order chest X-rays for people who might have respiratory conditions that I know what's going on. Like I know this person's having an asthma attack. They're having an asthma attack. They don't need a chest X-ray. They need some steroids right away, right? Because that is the gold standard treatment for asthma. Now, if I give somebody steroids and they don't get better, now I need a question answered. So now I might order a chest X-ray, right? Because now I'm saying, could this be an infection that I'm missing, right? But if you had an infection, patients should be febrile. They should be spiking a fever. The white count should be elevated. So there are other things that are leading me down the road of maybe this is an infection. Let's get a chest X-ray. I can tell you that about 3 weeks ago, I had COVID, and of course, my nurse at my clinic, she tested me and then politely sent me home. So when I went home and I was doing okay, but then like in the evening, I started to get like to Dr. Miller's point, you ain't never had no feeling like when you can't breathe, okay? And I was sitting there like, I can't catch my breath. I'm like, I can't catch my breath. So it's interesting when you're the patient and I'm saying now, and now mind you, I'm sitting there like, what would I do if my patient is telling me what I'm saying to myself? And I said, so I called my wife. I said, hey, listen, you got to take me to the ER because I said, I can't catch my breath. And so, but when I got to the ER, they gave me a neb treatment. I felt better, but they also gave me a chest X-ray. But why? Because I had a low-grade fever. So I'm saying the chest X-rays are not necessarily something you just want to be ordering just because. It's really to answer a question. And sometimes people can't breathe, and we know exactly why you can't breathe, right? If you're having an asthma attack, you have allergies, and you just went into a warehouse, that answers every question I need. I'm going to give you steroids. I'm going to give you some albuterol, beta-2 agonists. and you should get better, right? But if you don't get better, and I'm still hearing a lot of wheezing, I'm like, does this person have heart failure? Do they have an infection? Do they have a pneumonia going on? Now I want to get a chest X-ray.
Well, outstanding. I was actually going to leave this statement for next week, but I think you answered this person's statement, so I'm going to go ahead on and read it. They said, Dr. Miller, TB, people are still getting TB. I thought COVID took over for TB, and then I thought COVID was gone. Well, Dr. Pete just had COVID a couple weeks ago, and TB is still around. It's two different diseases, so let's keep that straight.
No, we did go through a period of time where we had TB kind of subdued, but TB has rebounded.
Yeah. Well, Catherine Jones says, Jesus, Jesus, Jesus. And with that being said, we're going to have our Until Next Mondays. Well, Dr. Mason, your Until Next Monday.
Well, one of the things I want to say is that this has been a great conversation. I hope people take it to heart and realize that if you have other conditions, particularly conditions that are respiratory conditions like asthma and what have you, you really, if you're still smoking, you are playing with a loaded gun. And so you really do need to stop smoking. And if you have difficulty doing that, there are some things. I'll ask your doctor about what things might be available or what treatment you might avail yourself to help you stop smoking. Because smoking and asthma, they're a lethal combination. And I just wanted to put that out there because I see so many people who have asthma and they're taking medicine for their asthma, but they're still smoking cigarettes.
Well, Dr. Mason, you said a mouthful. Stop smoking cigarettes with asthma. And then we had a comment that says, what about the people who have oxygen nasal cannulas and they're smoking just as well? So you guys hit the nail on the head. Also, Stanford said, Dr. P, you are right. Answering a question. Order the test to answer a question. Stop answering the question of an ABG. Well, I could agree with Stanford on that one because I believe an ABG test was created by the devil. I know you have to answer the question, but that test is ridiculous. Well, Joe Harrington, you're Until Next Monday. You're muted, Joe.
I got to come off mute.
There you go.
Well, Nikki, when you indicated you want to talk about respiratory disease before discussion, I thought about what I would like to say, and it's sort of related, but not directly related. But I think it is an opportunity to make a point. People may recall that on May 25th, 2020, George Floyd, a black man, was detained by the police in Minnesota outside a shop. He died in police custody while an officer knelt on his neck. His final words were, "I can't breathe." It became a rallying cry for justice, a movement against police brutality and racial injustice. Well, with this current administration, it's making me very difficult to breathe, and I'm very nervous. And the only thing that I can advise people to do is when an election comes around, if you feel like I do, exercise your right to vote, but please do something to change the way things are.
Well, Dr. Mason said, stop smoking. And basically, Joe Herring just said, exhale and vote. Well, Dr. Miller, you're Until Next Monday.
So my until next Monday kind of reaches out to the point that you gotta look out for yourself. Don't just do things because somebody else is doing it. You know, we were talking about cigarette smoking, and I remember when they used to have the advertisement on television, and cigarettes were supposed to make you look cool or make you look like you were, or you relate to being some kind of superhero. Look out for yourself. Don't take other folks don't take all the advice, especially that which is coming in advertisement, because it's simply to get you to spend your money. So look out for yourself. Make certain that you protect yourself and all these things. I like the comment that the man made on the plane to the congressman, that he was at least show some concern for others by saying, I have a condition. You might want to put this on to protect yourself. And so, these are things that we really want our community to do: protect each other and protect yourself.
Outstanding. Well, Dr. Mason said to stop smoking. Joe said to exhale and vote. Dr. Miller said basically be a trendsetter, be selfishless. Well, Pete, you're until next Monday.
So until next Monday, I agree with my colleagues. I would also just add to make sure that you are getting your necessary vaccines to assist in preventing infections. I will say none of these vaccines are 100%. So my patients sometimes say, well, I got the flu vaccine, so that means I'm not going to flu. I said, I didn't say that. I just said it was going to reduce the risk. So now sometimes these vaccines, we're predicting what next year's vaccine or what next year's flu virus might look like. So it's just a prediction. So they might be 67% effective, but I'll take that 67% effectiveness because again, the flu kills 80,000 people a year. I said kill, not in the hospital. Over 100,000 hospital admissions happen as a result of the flu. So you tell me if you have an asthma, if you have COPD, if you have any sort of underlying respiratory condition, it behooves you to get the vaccine every year. It helps to reduce that risk, but also you got to stop smoking. We have great medicines out to help you do that. We have Wellbutrin, Chantix. We got nicotine patches and gums and lozenges. We have all sorts of things that we have available for you. Ask your primary care doctor for it, and also be cognizant of the things we learned during COVID, which is your hands being placed on public places and wearing your mask when you are in an enclosed environment. The congressman taught us that, right? But you have to assume, like, what if that person didn't say that to you? Like, didn't say I had a cold? Like, you almost have to say to yourself, because I see people all the time wiping their nose, and I'm saying, man, give me a mask, give me something, because I can't deal with my man here wiping his nose so much. so, but it's not. I'm not trying to say there's nothing wrong, but the point is you have to protect yourself, guys, and who are you going to come in contact with? That's not fair for that person. You on a plane with my man who's wiping his nose all the time, and you should have your mask on. Okay, so that's all I got to say. But until next Monday.
Well, Congressman, take us home.
I think what we have heard this evening is nothing takes the place of everything else. And that is you gotta do it all.
Yeah.
You gotta rely upon all of the instruments that you can think of and follow the doctor's orders. Make sure you do the protective things that you know how to do. Make sure you pay attention to the research. Follow what the research has told us. And when you get through doing all of that, then pray a little bit and vote. You got to do every bit of it.
All of it, yeah.
It's kind of like the song that used to say, love and marriage go together like a horse and a carriage.
That's right.
Brother, you can't have one without the other. And so practice all of the elements that we've heard about. So thank you, gentlemen, for a very informative Monday. And until the next Monday, I'd love for us to think about the fact that we need facilities. And we've got several hospitals in our communities that are on the verge of only being able to make payroll. for maybe 2-3 additional months, especially as these Medicaid cuts take effect and as all of the other things that are coming down the pike. I met for an hour and a half Saturday with the president of one. There is another one that I'm very familiar with. There is another one that I'm very familiar with. And they're all in crisis situations. So let's pray for them too. And until next Monday, try and figure out what we can do. Thanks to everybody, and have a wonderful rest of the night. See you all.